Good afternoon and welcome you all to this webinar. Amidst of COVID-19 pandemic stress, let us have some diversion with recapitulation of some of the important facts in our day-to-day practice. So let me present the role of mineralocorticoid receptor antagonist, also known as aldosterone antagonist, in case of heart failure, myocardial infarction, and resistant hypertension. Next one. Yeah, before going to the mineralocorticoid receptor antagonist proper, let us how aldosterone acts. As we know, the mineralocorticoids that aldosterone binds to the cytosolic mineralocorticoid receptor on the epithelial cell of the distal nephron and many tissues in our body. These cytosolic receptors are the ligand-dependent transcription factor. On binding of the ligand, that means aldosterone, they translocate to the nucleus, which upon in the nucleus they bind to some of the site of the promoter gene and then regulate the expression of multiple gene product called aldosterone induced protein, that is AIPs. These AIPs are responsible for multiple cellular action of aldosterone like salt and water retention and excretion of potassium and hydrogen from the renal tubules, then on vascular and myocardial tissues causing fibrosis, inflammation, calcification, etc. The mineralocorticoid antagonist acts by binding to these MR receptors and block the aldosterone effect by competitively inhibiting the binding of aldosterone to these type 1 receptors, not only in the distal nephron tissues, but also many tissues in our body, especially the vascular tissues, cardiac tissues, and also as well as in the brain tissues. Next please. So according to the classification, the mineralocorticoid receptor antagonists, they have divided in the first generation, second generation, and third generation. The first generation is well known, that is spironolactone, and the second generation is eplerenone, and the third generation, which are under recent clinical trial, ARTS heart failure trial, finrenone. Next. So acting on the different tissues, aldosterone have their actions, like in case of renal tissues, it's reabsorbed sodium. By reabsorbing sodium, it expands the plasma volume and causing edema. In the heart tissues, myocardial cells, it causes myocardial fibrosis, as well as, especially in a setting of LV dysfunction, it causes cardiac remodeling, especially after myocardial infarction. And in the vascular cells, it causes vascular endothelial injury, leading to endothelial dysfunction, also as well as vascular fibrosis. It also causes cardiac excitability, thereby causing different kinds of arrhythmia and also affects the thrombogenesis. This is physiologically, they act on different tissues of cardiovascular system. This aldosterone is secreted by zona glomerulosa of adrenal gland in response specially to RAS activation, that is renin-angiotensin-aldosterone system. This molecule was first identified Simpson and Tate approximately 5 decades ago. On continual use of AC inhibitors or ARBs or both, there is a phenomena which is known as aldosterone escape. That means even after the inhibition or blocking of the angiotensin 2, which was the stimulus for aldosterone secretions, it escaped the effect of angiotensin 2 blocker, and slowly the level of the aldosterone in the blood increases. So in that case, the aldosterone MR antagonists have the role. So we can thereby completely block the rush systems. The first generation molecule, spironolactone, acts functionally as a competitive inhibitor of mineralocorticoid or aldosterone receptor. And although it is effective mineralocorticoid receptor antagonist, it has some deleterious effects. We have some limitation of spironolactone, like it has some unwanted progestational effect. Also, it has some anti-androgenic side effect, like gynecomastia, painful gynecomastia especially, then menstrual irregularities, impotence, etc. The second generation eplerenone is a competitive antagonist, somewhat more selective antagonist that take the advantage of replacing 17 alpha thioacyl group of spironolactone with a carbomethoxy group and conferring excellent selectivity of the mineralocorticoid receptor over other steroid receptors. And thereby we can decrease the side effect of the spironolactone. The pharmacological profile of eplerenone position it to be the more effective and more selective mineralocorticoid receptor antagonist. The aldosterone antagonist, the first evidence that showed a major clinical benefit, especially in heart failure, is the RELISE trial, randomized aldosterone evaluation study, which was published in 1999 with spironolactone, which has been used from the dose 25 to 50 milligram daily. And it decreases the total mortality significantly by 30% and total hospitalization for heart failure by as high as 35%. And because of this significant mortality benefit, this trial has been stopped prematurely after 24 months. So what are the trials in relation to eplerenone? The landmark trial are emphasis heart failure and Ephesus trial. Now we'll go one by one. The emphasis heart failure trial, which was published in 2011 in New England Journal of Medicine. Yeah. So eplerenone added to the evidence-based therapy is associated with improved clinical outcome in patients with systolic heart failure with mild symptoms. The trial is eplerenone in mild patient hospitalization and survival study in heart failure. Aim to assess the effect on clinical outcome of adding eplerenone to evidence-based treatment for mildly symptomatic NIHA class 2 heart failure patients. Total 2,737 patients were enrolled with NIHA class 2 systolic heart failure with ejection fraction less than 35%. And they are randomized to receive along with recommended standard therapy of heart failure. In one group it is placebo and other group it is eplerenone up to maximum 50 milligram per day. The primary outcome is a composite death from cardiovascular cause and hospitalization for heart failure. So many investigators from India also took part in these studies. The patient enrolled were more than 55 years of age, having NIHA functional class 2 symptoms, ejection fraction mostly below 30%, and patient in between 30 to 35% when their QRS duration is more than 130 millisecond. Treated with recommended or maximally tolerated dose of standard medication like AC inhibitor and or ARB or both, and beta blocker unless contraindicated. Within 6 months of hospitalization for cardiovascularism, or if no such hospitalization, then the level of BNP or pro-BNP are included in the inclusion criteria. The patient having more than potassium 5 millimole and eGFR less than 30 ml per minute per 1.73 meter square surface area were excluded from the study, and those patients are having a need for potassium sparing diuretic, they are also excluded from this trial. So what are the outcomes? So in this slide we have seen the cardiovascular death and heart failure hospitalization. In eplerenone group it is 18.3 as against 25.9 in placebo group, and cardiovascular death is also 10.8 as against 13.5. Heart failure hospitalization 12.0 as against 18.4, and hyperkalemia incidence of hospitalization for hyperkalemia is 0.3 as against 0.2 in case of placebo. So this is the result showing the primary endpoint, that is cardiovascular death or hospitalization for heart failure, which is significantly reduced in eplerenone group by 37%. And the benefits start, if you can see, the benefits start very early after the starting of the therapy, and it maintained for long term. This is the death from any cause, which is also seen is less in eplerenone group than in the placebo group. And this is hospitalization for any reasons. It is also significantly different from placebo group. And this is hospitalization for heart failure. We have seen that in eplerenone group it is significantly less, and the graph are well separated at the very early. That means benefits start very early in the course. So in summary, primary outcome in eplerenone group it is 18.3 as against 25.9. CV death 10.8% as against 13.5%, and high incidence of hyperkalemia 11.8% in eplerenone group as against 7.2% in placebo group. So addition of eplerenone to recommended treatment resulted in a 37% reduction in the rate of composite outcome of death from cardiovascular cause or hospitalization for heart failure. There are 24% reduction in the rate of death from any cause, 23% reduction in the rate of hospitalization from any cause, and 42% reduction in the rate of hospitalization from heart failure. The effect of eplerenone on the primary outcome was consistent across all pre-specified subgroups. In patients with systolic heart failure and mild symptoms, in addition of eplerenone to the recommended medical therapy is well tolerated, it improves survival, and it also prevented hospitalization. So we believe that the robustness of this finding in conjunction with the consistent result from the earlier release trial and emphasis trial provides a compelling evidence to sense the medical practice. There are some subgroup analyses, and whether use of aspirin reduces the effect of benefit of mineralocorticoid receptor antagonist. So in this trial, aspirin used in patients with chronic systolic heart failure and mild symptoms did not substantially reduce the overall beneficial effect of MRA eplerenone, contrary to what has been described in some studies with ACE inhibitors. And whether the duration of the QRS and morphology of QRS affect the clinical outcome in the eplerenone group. So moderate prolongation of QRS duration and presence of right bundle branch block, left bundle branch block, or non-specific intraventricular conduction defect were associated with a high risk of adverse outcome in heart failure patient with reduced ejection fraction. Even in this group, the eplerenone was similarly effective irrespective of QRS duration and morphology. So clinical benefit of eplerenone in patients with systolic heart failure and mild symptoms when initiated shortly after hospital discharge. So eplerenone is safe, it improves survival, and it may prevent readmission when initiated soon after a hospitalization for heart failure and acute coronary syndrome in patients with systolic heart failure with mild symptoms. The safety and efficacy of eplerenone in patients with high risk for hyperkalemia and or worsening renal failure. So in patients with chronic heart failure with reduced ejection fraction in NIHA functional class 2 and meeting specific inclusion and exclusion criteria, whatever we have already told, the eplerenone was both efficacious and safe when carefully monitored, even in the subgroup of high risk of patient developing hyperkalemia and worsening renal failure. Eplerenone also provides substantial benefit on the major events in patients with mild symptoms with heart failure, even in those already having high dose of standard background therapies. Eplerenone markedly reduces the risk of heart failure hospitalization in patients with heart failure and mild symptoms to a greater extent than is captured by only studying the time to first hospitalization. So these are the different subgroups where eplerenone shows its benefit. So whether this use of eplerenone is related to new onset diabetes mellitus. It has been also seen in this trial that eplerenone had no effect on the new onset diabetes in patients with congestive heart failure. In patients with heart failure with atrial fibrillation, what is the results? What is the benefit of using this? In patients with systolic heart failure and mild symptoms, eplerenone reduces the incidence of new onset atrial fibrillation and flutter. Also, effect of eplerenone on the reduction of major CV events were similar in patients with or without atrial fibrillation at baseline. This is the another trial of use of eplerenone, especially in post-myocardial infarction heart failure. So this trial also included 6,632 patients with acute myocardial infarction complicated by heart failure and systolic LV left ventricular dysfunction. So patient having acute MI in prior 2 to 14 days, presence of left ventricular dysfunction, ejection fraction less than equal to 40%, and heart failure in non-diabetic, but it is not required in case of diabetes. So these are two groups, eplerenone and placebo, and endpoints are death from any cause and death or hospitalization from CV cardiovascular cause. So we have seen here, this is the eplerenone group and this is the placebo group. So all-cause mortality, which is significantly less in case of eplerenone group, and CV death and hospitalization is also less in case of eplerenone group. This is the graph showing the difference between the placebo group and eplerenone group. Aldosterone inhibition improves survival in patient with post-MI heart failure and LV dysfunction. So this is total CV death, cardiovascular death. In eplerenone group, it is less than the placebo. So in a summary, the eplerenone significantly reduces all-cause mortality in patients with heart failure and left ventricular dysfunction, that is ejection fraction less than equal to 40% after myocardial infarction when compared with placebo. And eplerenone treatment in this setting also significantly reduced mortality from cardiovascular cause and hospitalization for cardiovascular issues. So here there are some guidelines. 2016 ESC guideline as well as 2017 ACC-AHA guidelines also endorse this molecule in this both setting. And what is their recommendation? An MRA is recommended for all patients with persistent symptoms, NIHA class 2 to 4, and with an ejection fraction less than equal to 35%, despite treatment with AC inhibitor or an ARB, if an AC inhibitor is not tolerated, and a beta blocker to reduce the risk of heart failure hospitalization and premature death. This class 1 recommendation with a level of evidence A. This 2017 ACC-AHA guideline for the management of heart failure also endorsed the use of aldosterone antagonists in these cases. So here they have mentioned the clinical strategy of inhibition of renin-angiotensin system with AC inhibitor or ARBs or ARNI in conjunction with evidence-based beta blocker and aldosterone antagonist in selected patient is recommended for patient with chronic heart failure with reduced ejection fraction to reduce morbidity as well as mortality. This is another recommendation. So whether it is also useful in case of heart failure with preserved ejection fraction. So in normal ejection fraction patients, the systolic and diastolic blood pressure should be controlled in accordance with the published clinical practicing guideline to prevent morbidity. And diuretic should be used. So we can use aldosterone antagonist as a diuretic for the relief of symptoms due to volume overload in this patient with heart failure with preserved ejection fraction. So what is the role of mineralocorticoid receptor antagonists in case of resistant hypertension? So we know the resistant hypertension can be defined as failure to achieve the goal blood pressure that is below 140/90 despite the use of 3 or more different drug classes with their optimal dose, and including ideally one of the 3 has to be a diuretic. Or if blood pressure is controlled but it requires more than equal to 4 antihypertensive agents of different drug classes, then we can label it as a resistant hypertension. So before going to treat, we have to address these issues. Whether we really address with a resistant hypertension, or whether it is a refractory hypertension, or whether it is a case of difficult to treat hypertensions. And all are same, or whether there are differences. Are all patients with resistant hypertension different from those with mild hypertensions? Why does the same antihypertensive therapy produces markedly different BP response in different patients? And how best to start treat the resistant hypertension when identified? So let us discuss. So before diagnose a patient of having resistant hypertension, we have to rule out whether it is a part of pseudo resistance. That means whether it is related to poor BP technique, blood pressure measuring technique, whether it is due because of some poor adherence to the therapy, or it is a part of white coat effect, or whether it is a part of non-compliance from the patient part. So after excluding all these causes, we can diagnose resistant hypertension as per the definition. So this slide is showing the role of aldosterone antagonists in case of resistant hypertension. And here, after use from the 6 weeks to 6 months with aldosterone antagonist, the mean blood pressure, both systolic and diastolic, is progressively decreased. We have seen here. And this is the mechanism of hypertension, the role of different systems, how it takes parts. So some patient, this is a spectrum of pathophysiology. So in some patients, both sodium retention and the RAS and SNS has take part equally. And in some patient, there is a role of sodium retention is more than your RAS and SNS. And in some patient, the activation of RAS and SNS is more dominant than the sodium retention. And this category, ultimately, if there is a sodium retention is more dominant, the patient is having excess volume expansion, and in that case, the use dietary sodium restriction is beneficial, and also use of diuretics definitely be indicated in this category of the patients. And in this category, because of this activation of RAS and systemic nervous system, the vascular resistance predominant over the volume expansions. So role of beta blocker and RAS blocker are more important in these cases. So according to the pathophysiology, which is taking part in the resistant hypertension and which is dominant, we have to direct our therapy accordingly. So what are the general recommendations to treat resistant hypertension? As we all are aware that lifestyle modification is indicated in all patients, like weight loss, regular exercise, low salt and high fiber diet. Then standard triple regimen of AC inhibitor, ARBs, thiazide diuretics or other diuretics, and long-acting calcium channel blocker is the first choice. Then preferential use of chlorothalidone over hydrochlorothiazides. It is now coming up. Then consider the use of aldosterone antagonist as the fourth line of treatment if it is not adequately controlled by all these three class of therapy. Then even after addition of spironolactone, or that means aldosterone antagonist, we can take the help of other class of drug. This is the slide showing the blood pressure, especially the SBP, systolic blood pressure sense, along with the use of aldosterone antagonist. So there are different different studies which showed the role of aldosterone, hyperaldosteronism, either primary or secondary, especially primary aldosteronism, which are related to the resistant hypertension. So primary hyperaldosteronism is present about 20 to 30% cases of resistant hypertension. So these are the different studies. So the prevalence of primary aldosteronism in case of resistant hypertension. This is the trial pathways to the first RCT, which showed that spironolactone was far superior to alpha-1 blocker doxazocine, and bisoprolol in case of hypertension. This study provides a new evidence for an old idea, the miracle of low-dose spironolactone for resistant hypertension, which was published, titled in 1972, Clinical Pearl, article penned by the late Dr. John Lurard. And JNC8 recently also has endorsed as a fourth class of drug in difficult cases of hypertension as well as in resistant hypertension. So these are the class of treatment for resistant hypertension. So if it is not controlled, then we have to further increase or add the diuretic therapy like high dose thiazide diuretics, and we can add spironolactone, eplerenone, even amiloride. Then we can take the help of sympathetic nervous system blocker in case of the patient with normal or high renin status. That is the patient category with a sodium retention is a dominant pathophysiologic factor, and this is the category where RUS and SNS is the dominant factor. So this trial showed that add-on use of eplerenone is effective for lowering of home as well as ambulatory blood pressure in case of drug-resistant hypertension. And on conclusion, they say in patients with drug-resistant hypertension, the add-on use of eplerenone was effective in lowering blood pressure, especially home and ambulatory wake blood pressure. Furthermore, it has also showed that endothelial function was improved by eplerenone without causing significant adverse effect. This is another trial of uncontrolled hypertension. So addition of therapy with eplerenone effectively lowered blood pressure in patients with difficult to treat primary hypertension. So what guidelines say? ESC and ESH 2013 treatment recommendation for resistant hypertension, they say a good response has been reported to the use of mineralocorticoid receptor antagonist, that is spironolactone, even at low dose, or eplerenone, or the alpha-1 blocker doxazocine, or a further increase of diuretic dose with a loop diuretic replacing thiazide or chlorthalidone if renal function is impaired. This is European Society of Cardiology and European Society for Hypertension 2013 treatment recommendation also said that given that blood volume may be elevated in refractory hypertension, amiloride may have an additive effect with a previously administered thiazide or thiazide-like diuretic. Although this does increase the risk of hyperkalemia, and its use is not recommended in patients with markedly reduced eGFR. The BP response to spironolactone or eplerenone may be due to the elevated aldosterone level that is frequently accompany resistant hypertension, either because of aldosterone secretion escapes the early reduction associated with RAS blockade, or because undetected primary hyperaldosteronism because of the hyperplasia of the adrenal gland. So thank you for patient hearing. I have to thank you, the Lupin peoples, for giving me the chance to speak few words in relation to the aldosterone antagonist. Thank you.
Sir, there are few questions in chat box.
Yeah. So one question: what should be the level of potassium and serum creatinine while patient is on eplerenone. Already I have told, and these two trials, they have excluded the patients in which the potassium level is more, so especially 2 to 2.5. They have excluded from the trial potassium 5.5 and creatinine. Sorry, creatinine level is 2.5, 2 to 2.5, and potassium level in the upper normal is, that is 5.5 milliequivalent per liter. So if patient is having potassium more than 5 or equal to 5.5 or more than 5.5 milliequivalent per liter, then we should not use or should not consider for aldosterone antagonist. So before that and before that level, if it is required, if it really required by the clinical scenario, that means if patient is having resistant hypertension, which is not controlled well by all the three classes of drug with optimal doses, and in case of heart failure, if patient is still symptomatic with the use of all the standard therapy with optimal dose, then we might consider this aldosterone antagonist, either spironolactone or eplerenone, as the clinical scenario detect. But with a special concern about whether it increases the potassium and creatinine, we have to look for. So we have to do potassium estimation, both potassium and creatinine, after 3 days of the starting of the therapy. If it is increases, then we have to stop or at least decrease the dose. And after 7 days, we also have to repeat. And thereby, if it is not increases at monthly interval for a few months, and after that, as the clinical scenario demands. So we have to be very much cautious. If patient with already have chronic kidney disease, having a upper level of both creatinine or potassium, and we should closely monitor those patients, especially if the patient is already on AC inhibitor or ARBs, and along with that, we are going to give aldosterone antagonist. Next question, sir. What studies and trial indicate eplerenone to be better than spironolactone in heart failure? Actually, still we do not have any head-to-head trial with spironolactone, because it is the same class of molecule, but with some added advantage of having less side effect in case of eplerenone. The eplerenone is more specific aldosterone antagonist. It is more specific and somewhat more potent. But before selecting these two, whether we are going to use spironolactone, which have some side effect, common side effect like gynecomastia, painful gynecomastias, and menstrual irregularities, importance, which are somewhat lesser or even negligible in case of eplerenone. But at the same time, we have to consider the cost of the therapy, because cost of the eplerenone molecule is somewhat 3 to 4 times more than the spironolactone. So we can start spironolactone if patients do not have any adverse effect, especially related to what I have already told, that is gynecomastia or impotence or menstrual irregularities. Then you can continue spironolactone, because more or less it is same, and all what we have studies, both molecules are showing very significant benefit in terms of mortality and in terms of rehospitalization from heart failure, from patient with myocardial infarction with LV dysfunctions, and also in some cases of resistant hypertension. The next question, I think, if time allowed, I can. Does eplerenone have any interaction with aspirin? Yes, that is also well addressed in this trial. I have already showed the slide that it is fair that the aspirin, in some studies it has been shown that use of aspirin in heart failure along with AC inhibitor or ARBs, they impair the effect of AC inhibition. But in case of use of spironolactone in this trial, even with use of aspirin, it has not been seen that any difference between the action. So we are having same benefit in patient with aspirin and even without aspirin. That subgroup analysis I already shown. Next question, what are the side effects of eplerenone? So as a group, we can have very minimal side effect, already I have told, of whatever we have seen along with spironolactone. But the incidence of gynecomastia and other side effects which affects because of anti-androgenic effect or because of progesterone effect are somewhat less and very much negligible, because it is a very selective aldosterone blocker in relation to spironolactone. The only important side effect we have to consider is hyperkalemia and deterioration of the renal function, especially patients already have a high creatinine level, or those who are at risk of developing hyperkalemia. So in these two, we have to look for in these two categories, especially hyperkalemia and increasing of serum creatinine. These are the main two side effects, and other side effects of aldosterone antagonists are very, very, very rare in case of eplerenone. So next question, does eplerenone affect the heart rate? In these two trials, and theoretically also, it does not have any effect on the heart rate. I don't think that eplerenone causes weight gain. Another question, does eplerenone causes weight gain? I don't think, because it reduces sodium reabsorption, thereby it reduces plasma volume. So whatever weight gain in case of all this category of patient is because of fluid overload, and that is decreased by aldosterone antagonists. So I don't think that eplerenone causes weight gain by any mechanisms. Another side effect of all these aldosterone antagonists is GI side effect. This is somewhat again more prominent in case of non-specific blocker like spironolactone, especially acute gastritis, even gastric ulcer, even bleeding gastric ulcers. So patients who are having peptic ulcer, especially active ulcer with GI bleed, in that case we have to be very much cautious before starting aldosterone antagonists. Again, this is somewhat less in case of eplerenone. So I think there is no more question. Thank you. Thank you for patient hearing and taking part in this.
Thank you so much, sir, for your insightful.
Thank you. Thank you for your technical support also.
Okay, sir. So we conclude the session here, sir.
Okay, thank you.